Hi, it's Dr. Mike Stoner doing November's MEC Minute. I hope everybody's getting ready for Thanksgiving. This month we're going to talk about some pediatric viruses. I will say that if you decide to catch this out right before the end of the year, this may all be past, but right now it's pretty time sensitive. Mostly we're going to talk about bronchiolitis. We're seeing quite a bit of that, and then we'll touch on some measles updates. Well, so as most of you know, bronchiolitis is a infection of the lower respiratory system. It affects mostly the smaller airways, and that's why you'll hear a lot of wheezing. People always associate RSV, or respiratory syncytial virus, with bronchiolitis. It is the most common cause, but they are not synonymous. There are others. Usually it's the infants the hardest, and the really young ones, probably about a month of age, maybe 6 weeks, you might see some central apnea, meaning that they just stop breathing, which is not ideal. And the most important thing, it is here right now. This is our local virogram, respiratory viruses that we're seeing within central Ohio. This comes to us from Nationwide Children's. That's where I stole this information from our lab. And you'll see it kind of runs through May all the way up through about 2 weeks ago. And the pea green is RSV, as you can see, and we've just have a huge volume of that. We're also seeing a little bit of flu starting to rear its ugly head, which makes it less than ideal when you have two viruses hitting at the same time. So what are the symptoms of bronchiolitis? As many of you have seen it, it starts out kind of as a cold. You'll get some congestion, runny nose, and cough. Babies will get a fever as well. And then as it progresses down to the lower airways, you get some increased work of breathing. You'll see some wheezing, some fast breathing, struggling to breathe, and some significant retractions. Some of the risk factors for having severe disease are the really young, under 12 weeks of age, those that are premature or less than 36 weeks of age, the smaller ones, under 5 pounds. If you're working your way into the older kids, it's some with chronic lung diseases, airway abnormalities, heart disease, immunodeficiency, neurological disease. But your run-the-mill bread and butter bronchiolitis affects mostly the younger ones, and the severe ones are usually the smaller infants. One thing I did want to mention in the previous slide, I guess, would be we're seeing a little bit older this year as well. This running theory is that older by meaning like 1 and 2 year olds who are having some issues with it, and the running theory is that we've been wearing masks for a while and people really haven't been exposed to it, so we didn't hit the older kids last year as much as we have previously, so we're seeing 2 years worth. Treatment, unfortunately, bronchiolitis is one of those that there's not a lot of treatment. What are you guys going to do in the field? You always think about your ABCs, and with bronchiolitis, it's mostly A and B. The airway is pretty congested and hard to breathe through, so you want to clean that out. I guess starting on, the first thing you do is prevent it. Well, unless you go out right now and wrap every kid in a plastic bubble, which would also be hard to breathe through, prevention is kind of difficult. There is no vaccine as of yet. A few have trialed. The problem with vaccines for bronchiolitis is, as I mentioned, it hits the really young ones who are probably too young to be vaccinated. The latest one that I heard about was maternal vaccination that hopefully will spread across the placenta, and the kids will have a little bit of immunity when they're younger. and that way they would increase their immunity, is kind of how that would work. And then finally, the treatment per se, I mentioned ABCs, is kind of a stepwise approach. You clear out the airway with nasal suctioning. If you need to support their breathing, you can. We'll get into that in a second. And then time. There's a current national push here that is kind of catchy and says rest is best. Trying to get people to use less uh, adjuncts that we've used or tried in the past and haven't done a whole heck of a lot. Albuterol, everybody hears a wheeze, everyone wants to throw albuterol at somebody. It doesn't really seem to help that much. It does make them jittery and kind of irritated at times. Steroids are good anti-inflammatories, but this is an infectious process, not really. There is inflammation, but they don't really help. People have tried to increase secretions or at least dilute things with some hypertonic saline. While that does help out a small smidge, it does not, the studies show that doesn't really decrease your length of stay in the hospital. And then racemic epinephrine, there was one good study years ago that said this was the best thing, and then about 20 studies after the fact that said, forget it, doesn't really work. My theory is that it kind of, like Afrin made with the epinephrine, made the nose shrink a little bit, or the tissues kind of constrict a little bit, so they breathe for a good few minutes better, and then got worse again. And then X-rays. This is not something we'll be doing in the pre-hospital arena, but it pushes across the country to decrease X-rays because every kid with bronchiolitis has bronchiolitis in their X-rays, always read by our magnificent radiologist as consistent with bronchiolitis. If the story is atypical, that changes, but for the most part, kids will probably not be getting an X-ray when they come in. So what do we do here at Nationwide Children's or in Central Ohio? Uh, a new pathway, which is developed in conjunction with some of with the research that's out there, plus the Academy of Pediatrics pathways, but they kind of break it down into small, medium, large, or cold, warm, and hot, of low, moderate, and high severity. And it goes off, how fast are they breathing to age, how much work of breathing are they having with the retractions, or some mild, or just really tugging, and then how do they sound? Are they moving air? They're not even moving air at all. So then what do we do? Like I mentioned before, you kind of clear the airway, nasal suctioning, no matter what you do, how sick they are, you want to kind of open that airway up. Kids like to breathe through their noses, and if it's plugged, they have a hard time breathing. So we'll do bulb suction, we'll do some deeper suction. Not a huge fan of deeper suction constantly because it can irritate the lungs, but just some aggressive suctioning. Checking their oxygen, and if they need oxygen, give them oxygen. I would say from a pre-hospital field, it's probably 90% where you want to keep it, or above, where you want it to be. When they fall asleep, we'll let them dip down into the upper 80s, but they're probably not sleeping when you guys pick them up. And that's about all the treatment we have. Antipyretics, if they have a fever, get the fever down. We will, at some point, decide if they can eat and go home, but that's probably after the fact. Then I've been asked a million times, what about albuterol? It seems like I walk into the ED, I drop a kid off, and you guys are using albuterol on everybody. And it's probably true. The strict guidelines, what I was mentioning before, kind of say, no, there's no use for albuterol. Well, we find that in kids that are a little bit older, kids that have a really strong history of, or have a family history of some type of um, allergy-related illness like asthma or eczema or seasonal allergies, that we might try it once and see if it helps. And some kids it does, and some kids it doesn't. I think we always uh, make sure that we are going into it with the idea, at least for the parents, that this may or may not work. If you do it and the parents are like, oh, they did something, I have to go home with this, it kind of hurts us on the other side. But for the most part, we try it on some of these specialized kids, and sometimes it helps. So what do we do after the fact? So they get here and they're breathing hard. We try the suction, we try the oxygen, we watch them, and And many years ago, we let kids breathe a little bit hard, and for the most part, they didn't tire out. They just breathed really, looked like they were working, and sometimes we would call them happy wheezers because they'd be smiling, playing, and wheezing to beat the band. But now we try to decrease some of their work of breathing by increasing oxygen with some high flow on the left side of the screen. You can see that. That just kind of decreases a lot of the dead space where there was an oxygen, increasing the oxygen there. You could argue adds a little bit of PEEP, but minimal, if anything. Or on the right side of the screen, if that's not working, we'll bump them up to some BiPAP. I think the picture there is mostly nasal, but we will either do a face mask to cover their mouth too, because in this picture, if he opens his mouth, it's going to shoot out there. So we'll either cover the mouth or do like the Avatar mask like we have on the trucks to cover their whole face. What else do we have? Well, for bronchiolitis, there's not a lot. We have suctioning. We have salt water, trying to increase there, just kind of loosen up some of that snot using just saline. And then we have time and more time. And it's one of those that has this discussion with parents all the time, and it is one of my least favorite illnesses because there's not a lot that we have to offer these kids except for keeping their airway open, supporting their oxygenation, and then just time. If they're breathing so hard they can't eat, we will give them IV fluids. If they're those younger groups, I say, get apnea, it's not uncommon to have the really young babies get intubated. And if they are just breathing really hard, we try to make it better with some kind of either high flow oxygen or positive pressure. And that's bronchiolitis in a nutshell. Why is it important? Because we are seeing tons of bronchiolitis right now. We are seeing so much. Our hospital is full. We have kids living in the ED now that should be in the ICU because there's nowhere else to put them. So you are going to get called for this, and I was going to say we're happy to see them. We are happy to take care of them. At some point, you've seen enough of them, but that's what we do. Bring them to the hospital, clean out their nose, give them air if they need it, and we will go with the rest. Now for some fun history. Uh, RSV was first noted in 1840, but did not have a name at that point. And then in 1956, it was found in chimpanzees, so it was named chimpanzee coryza agent. So our common day RSV is actually originally named chimpanzee coryza agent, but in 1963, then they uh, characterized the virus a little bit more and named it RSV. There's your history. All right, so that's our respiratory virus. Let's move on and talk a little bit about measles. What measles? Yes, that was the disease that was almost eradicated from the United States with vaccinations, and recently, and it reared its head a few years back when somebody went to Disneyland and transmitted it all around Disneyland. And now we've had a few people come in and traveled from Africa and brought in measles, and then took their kids to a daycare. So there's a daycare, one or two in northern Columbus, that has been transmitting measles to each other. So it is now becoming more of a thing. I think there's been, somebody told me today, 18 confirmed cases in Ohio, in central Ohio. So it is rearing its ugly head. So more fun facts. It looks like they found it in the fourth millennia, as when it first arose in humans, but then it kind of continued to spread throughout times. In the Americas in the 1500s, they developed a vaccine. They first isolated the virus in 1959, developed the vaccine in 1968. And then you can see over time it's been decreasing, and it's assumed that the number of deaths from measles is on the left side and the timeline's on the right side. You can see we've kind of decreased over the last, oh, I have to do math now, 40 years almost. So what's wrong with measles? Well, it's one of the most contagious or more highly contagious viruses out there. So it's very contagious, and it's expected that if one out of 10 people have it, if somebody has it, 1 out of 10 will not catch it. 90% of people will catch it if they're nearby. It spreads that easily. Supposedly it's by aerosols, by like sneezing, coughing, stuff like that. But it can also live in the airspace, living on moisture droplets for up to 2 hours. So it stays around the environment. I threw this in there because I thought it was interesting because you will hear a lot about, well, we don't want the MMR vaccine because it causes autism or it has mercury or it will give you a third eyeball or something of that nature. And it's actually one of the reasons we're seeing a little bit of an uptick of measles is one of the populations in I guess cultures, excuse me, one of the cultures in Columbus will get all their immunizations except MMR. They're very worried about that one. So just a little myth busting. I gave you the fun fact about chimpanzee coryza agent. Here's the myth bust: is that the preservative that people were worried about, thimerosal, does not contain the toxic form mercury. Um, and it was removed from all vaccines in 2001, and it was never in MMR. Uh, People go back to this study from 1998 about increase in autism with MMR. It's actually, autism is usually diagnosed about the same time you get your MMR, just because that's the age that kids start to display the behavior. But they found that it was a fraudulent study. They got published, um, and they've debunked it and pulled it out, and have, I think the person who wrote it lost their license, but the myth still is there. Once you've done the damage, it's still there. Um, and the final myth is natural immunity is preferred, and it's not. It's a misconception. Immunizations work just fine. So what is it like? What is measles like? Well, it's usually it's a 8 to 12 day incubation period after you have hit it, but it can be as early as 5 days of getting exposed to having symptoms to up to 3 weeks. Um, and it's considered to have two periods of it. The prodrome phase, which is 2 to 4 days prior to the rash onset, in which you'll have some flu-like symptoms. You might have cough, congestion, um, fever, and conjunctivitis. We talk about the 3 C's. You have fever, then you have cough, congestion, and coryza, conjunctivitis. Cough, coryza, and conjunctivitis, um, which is like congestion, are the 3 C's of measles. Other stuff, you can get some generalized throat ache, headache, and just some lymph node pain. You also can get some Koplik spots, which are little itty bitty white spots on your soft palate and in your gums on your inside of your mouth. Right there. So I have no pointer, but you see the little white spots. Those are Koplik spots that are associated with measles. Usually you'll get some of these symptoms. You're infectious from 4 days before the rash until 4 days after the rash. And usually the symptoms start prior to the rash phase. Um, so that was the prodrome phase, which I said was the two distinct periods. The second period is the rash, and usually gets some macules. It starts on your head and works its way down. So it'll spread from your head down to your torso or your trunk, and then down to your extremities. So here's a good picture of measles. It's courtesy of Google. But you can see kind of the rash. It'll start up on your head, but then work its way down. This patient on the left side's got some good conjunctivitis, which goes along with it, and the rash kind of starts as the spots and then conforms all together. Um, Peak of the symptoms, they occur about 1 to 2 days after the rash, and then you'll get your complex spots. They'll present beforehand, and they may persist after that time. We had a case here not so long ago. I didn't see them, but they had rash on their palms, and I usually think of a different virus that causes palmar and rashes on your hands and on your feet, not measles. But up to 25, a quarter to half of patients can actually have lesions on their palms. The rash usually lasts about 3 to 5, 7 days. The cough may linger a little bit longer, but like I said before, your infectivity is greatest from 4 days prior to 4 days after. So you think about it, you have a little over a year old with 3 days of a little fever, a little cough, a little runny nose. Is it measles? Is it flu? Is it COVID? Is it RSV? Um, what do you do? And why do you care? Well, most of medical professionals are immunized, and so you're probably protected yourself, but are you going to bring them into a hospital full of other people? And the measles vaccine is usually given at about 12 to 15 months of age. So if you bring them to children, there's going to be a lot of kids in the lobby that are younger than 12 to 15 months of age. So what are some clues? If they're not vaccinated against measles, which again, usually the kids that are under a year of age, or if they're refusing vaccines, will fall into that. Have they had any international travel? Well, that's a clue of where they've been, but also with the outbreak that we've had in Columbus, that may or may not be helpful. And do they have other siblings? Is there history of exposure to somebody else with measles, and how they're looking? So those are just things to think about. How does it help us, and how would it help you? Usually those kids, if we're worried about a possible measles exposures, we won't put them in the lobby. We'll stick them right into a room and kind of isolate them. If we have a negative pressure room, that would be ideal. We also will mask the family right when they hit the door, just to kind of make sure that they're not sitting in the lobby exposing everybody else. I know a lot of this sounds very similar to 2 years ago when we started talking about COVID. So why do we care? What are complications of it? Say you get a cold and a flu and it goes away. Well, measles actually is reported to hit many organ systems, almost every organ, and it can cause a little bit of suppress your immune system temporarily and break through some of your epithelial surfaces. You can get, and I go over some more symptoms here in a second, but it can affect many different organs. The younger kids under 5 and the older adults over 65 are the ones that have more of a problem. Most kids do fine. The ones that are more likely to get sick can end up hospitalized. But people dying from it is pretty. So what are the common complications? Ear infections, yes, you can get that. You can get some GI symptoms, some diarrhea. Some kids will get fevers high enough to get febrile seizures, um, but those two are usually benign and go away. You can get a pneumonia. Up to half of these kids get hospitalized with pneumonia, and they get pneumonia, get hospitalized. Or you can get a co-infection. We see this with some other viral illnesses too. So that's always bad. Measles croup, it's a thing. We know a lot about para-influenza croup, but measles croup, I don't know how long that lasts. Or you can get a secondary pneumonia, like I said, or tracheitis. with Staph aureus. The two scary ones are the neuro complications. You can get a post-infectious encephalomyelitis, um, which you don't want. It can cause in a third of the people up to, I mean, you get neuro symptoms. You can have ultramentation, focal neurological signs, you can have seizures, but up to a third of those kids will have a lifelong impairments. And then you can get to subacute sclerosing panencephalitis. I think I once referred to this as brain melt. I don't think that's really an accurate term, but you get some sclerosis and just it's after the fact, it's post-infectious, but can lead to demyelination of some of the nerve cells in the brain and ultimately to vegetative state, and people can die from it. So it's not a benign illness. Like I said, it's rare, not many people get this, but that's what we worry about, is something that's preventable causing a problem and leading to the previous slide with lots of various reasons to be hospitalized or lifelong problems that could have been prevented. Like I said, it hits most all symptoms. You can get, I'll just read them: pneumomediastinum, mediastinal emphysema, hepatitis, appendicitis, keratitis in your eyes. You can get myocarditis in your heart, pericarditis around it, or DIC. So, is there testing? I actually have a call out to our local uh, epidemiologist here, head of our epidemiology, about testing. Most of the testing I know of goes through the public health. So if you have a kid, we will, and are worried about it, we will call them and they will direct us. But there are testing for measles. So what do you do? Not a lot you can do. It's supportive. If you get a secondary infection, like we talked about, like an ear infection or a pneumonia, you can treat that with antibiotics. Um, Most kids are fine staying at home. You kind of make sure they stay hydrated, uh, and they don't have they don't have to be in the hospital or stay in the hospital. Keep their fever down with an antipyretic such as Tylenol or Motrin. And then how do you prevent it? Well, we've already talked about vaccinations. It's a live attenuated virus, viral vaccination. It's like I said, 12 to 15 months is usually when you get it, but you can give it down to, and then you get a second time between 4 and 6 years of age, but you can give it down to 6 months, 6 months of age, for those who are worried about if they've been exposed or if you're worried about going traveling. It's a really good, effective vaccine. It's 93 to 95% after one dose, and 97 to 99% effective after 2 doses. And for the most part, it's lifelong immunity. So you don't keep getting it like you do the flu shot every year. Um, Prevention, we talked about that for post-exposure. Let's say if you get a good real life example is our lobby in the emergency department that has had somebody with measles sit in the lobby waiting to be seen. They're not terribly sick with a fever, cough like every other kid uh, in the lobby, but they end up having measles and they've just infected or potentially infected the rest of the lobby. If you were there and immunized, you're fine. There's nothing really to worry about. But if your child's there and is under the 12 to 15 months and it has not yet gotten their vaccinations, then they do have to worry because they could get it. So what do you do for them? Well, there's a few different ways. If they're over 6 months of age, you can give the MMR vaccine to help prevent it, and that's within 72 hours of exposure. We've been giving some kids, when directed by the health department, immunoglobulin, and that's for the kids that are under 6 months of age who cannot get the MMR vaccine, or for kids that are under a year but over 6 months, but they've missed that 3-day window. And then IVIG is for kids that are immunocompromised or pregnant women. What did I miss? 6 days. So, like I said, it's 3-day window for the vaccine and a 6-day window for the immunoglobulin. So what can we do in the pre-hospital arena? Just be vigilant. If you're concerned about measles, make sure that when you encode that's known, and we will whisk them off to either a negative air pressure room or at least their own private room and not in the lobby until we figure out more. So to summarize, measles, it's very contagious. It's sent by droplets, and aerosols, like sneezes. Most of the symptoms are fever, rash, and the 3 C's, cough, coryza, and conjunctivitis, or red eyes. It's not a subtle infection. We saw the pictures. Your rash is pretty significant, but the prodrome, or the initial phase of it, can be similar to other viruses, and the complications are common. That's the biggest thing. That's the biggest reason that we try to prevent it. Is it's not so much the measles virus itself. So you have a rash and red eyes and you cough, but it's the complications from it that you are trying to prevent. Lastly, right before I started this, Dr. Zeeb said somebody asked about the enterovirus D68. Yes, more respiratory viruses. This is one. Enterovirus is a big group of viruses that cause fever and rash, and it's actually the one, it's in the family that causes hand, foot, and mouth disease, is an enterovirus. But there's a specific one we saw a few years ago, and it kind of pops up every few years, D68. It too causes the fever and the respiratory symptoms, some upper airway problems like cough, congestion, and runny nose, and then lower, some wheezing and shortness of breath. But there's also a very small percentage that end up having acute flaccid myelitis, where it's affected arm and leg weakness, neck, back, arm, and leg pain. People can have difficulty swallowing, slurred speech, some droopy eyelids, and just some facial weakness altogether. So it affects your muscle tone. Fortunately, I reached out to the same epidemiologist, and he said that we have not seen this in a few weeks, and it's very rare. So one less thing to worry about. Thank goodness. I think that about wraps it up on my quick respiratory viruses. Um, we got 10 days to Thanksgiving, I think. Is that right? Thanksgiving's coming soon. So happy Thanksgiving, everybody. And as always, if there's any questions, feel free to reach out. Thank you.